lectures. So I have the great pleasure of introducing Dr. Jacob Abraham today, who will be the inaugural speaker for our series. He is a cardiologist, Johns Hopkins trained with the Providence Heart Institute based out of Portland, Oregon. He is the division chief of advanced heart failure, and he will be talking to us today about implantable technologies for remote monitoring in heart failure. And he is highly published in this field and is on a number of committees, including the HF2 and the Intellect 2 committees. So please join me in welcoming Dr. Abraham. Dr. Abraham, thank you so much for joining us today.
Thank you. It's my pleasure, and I want to thank you and Dr. Beasley for the invitation and the honor of being the inaugural speaker for this tremendous series. So congratulations to you all for setting this up. Hopefully you've all had a chance to review the pre-lecture questions. And today I've been asked to speak about implantable technology for remote monitoring of heart failure. For those who are interested, I do tweet a little bit about this on now X, so feel free to follow. And these are my disclosures that are relevant to this topic. As was mentioned, I've been an active investigator in this space and was a co-founding member of a group called Hemodynamic Frontiers in Heart Failure, which is a academic research consortium of multiple centers that are highly active in the space of remote monitoring. Our learning objective today is to directly from the COCAT guidelines know the role of implantable technology to allow monitoring of patients with heart failure, including from afar, i.e. remote monitoring. And I want to begin by reminding all of you that despite all of the advances in pharmacotherapy and device therapy for heart failure remains a progressive disease that for patients who are symptomatic has a high rate of clinical events. These data come from the Emperor-Reduce trial, one of the most contemporary trials of pharmacotherapy that we have today. And you can see that particularly for patients with reduced ejection fraction, the rate of events, in this case, cardiovascular death or heart failure hospitalization, remains quite high at 15.8 events per 100 patient years. Another way to look at this is if you just look at the number of patients who are hospitalized or die at 1 year, it's quite high at around 12%. So that's a staggering and humbling figure for those of us who take care of patients with heart failure and speaks to the need for us to have additional therapies to reduce this residual risk. And even though we oftentimes use heart failure hospitalization and harder endpoints like death as an outcome in clinical trials, it's worth remembering that these events also apply to patients who aren't hospitalized. These data come from the Paradigm Heart Failure Study, which you'll remember is the study of sacubitril valsartan in patients with reduced ejection fraction. And they performed an interesting analysis where they just looked at the overall event rate in patients who had any intensification of therapy, whether that occurred as an outpatient in an emergency room where they might have received IV diuretics, or in fact, they received and required hospitalization for congestive heart failure. And you can see looking at the event rate plots, both for all-cause death and for cardiovascular death, any intensification of treatment was associated with a much higher event rate than the population that had no events, which are shown by the black diamond. And I superimposed on this the event rate of 15.8 events per patient year from the Emperor-Reduce trial, just to give you some sense of context of the addition of an SGLT2 inhibitor in a contemporary trial. So you can appreciate that our patients, despite our best efforts, are at high risk. Now, we know from data over the last 2 decades that most patients who require intensification of therapy or hospitalization for heart failure require that because of symptoms that are driven by congestion, that is volume overload. And it's critical to remember that congestion is actually a very complex pathophysiologic driver of heart failure events. And that pathophysiology includes sodium and fluid avidity by the kidney. It includes endothelial dysfunction and vasoconstriction, and it includes venous congestion with volume shifting due to neurohormonal activation and shifts from the splanchnic bed into the central vascular space. And all of these mechanisms conspire and lead to fluid retention, fluid redistribution, and vasoconstriction that ultimately culminate and manifest as an elevation of intracardiac pressures, including an elevation of pulmonary artery pressure. Pulmonary artery pressure elevation is particularly notable because that is the afterload that is imposed upon the right ventricle, and it is correlated closely with many of the symptoms that lead to hospitalization. Independent of our symptoms or patient symptoms, we know that the elevation in pressure and the congestion, the imposition of load on the right ventricle further complicate heart failure and further perpetuate heart failure, because right ventricular dysfunction is a key driver of visceral congestion, especially renal congestion, which leads to worsening renal function. And we know that independently, RV dysfunction and renal dysfunction, cardiorenal syndrome, are all independently associated with worse outcomes in heart failure. So from a pathophysiologic perspective, monitoring and treating elevations in pulmonary artery pressure has a sound basis in pathophysiology. Now, as clinicians, when we're at the bedside, our ability to detect congestion is well known to be rather limited. Despite all of the excellent clinical education, and I'm sure you're all master clinicians, our ability to detect congestion using conventional signs or symptoms of heart failure is relatively poor. You'll see that from this paper from 2010, the jugular venous pressure elevation does have the best performance characteristics, but overall it's relatively poor. And it's also worth remembering that in standard practice, we see patients episodically, usually for very brief clinic visits. And so our ability to manage patients longitudinally is also compromised by the very nature of our care models. There have been many attempts to improve heart failure outcomes through remote monitoring of surrogates of congestion, the most common of which still used in clinical practice, of course, are signs, symptoms, and daily weights. And there have been multiple studies that have used telemonitoring, oftentimes through nursing telephone support, to try to manage patients' heart failure, to manage their congestion using these standard practices. But these have not been consistently shown to improve patient outcomes. And even more advanced metrics from implantable cardiac devices have not been shown consistently to improve outcomes. And of all these trials, which have enrolled close to 10,000 patients, my most favorite is the Empower study, which was published in JAMA Internal Medicine last year, in which patients were actually paid. They were given an economic incentive to try to prevent heart failure hospitalization. And the negative result of this study confirms that you actually can't pay patients to stay out of the hospital due to the severity of their heart failure. So with that background, you can understand why there has been a concomitant effort to develop sensors that can be implanted within the circulation that may more accurately measure pressure and allow us to titrate our therapies in response to the underlying hemodynamic perturbations that drive the disorder. And over the past 3 decades, there have been multiple sensors that have been developed to be implanted in various locations within the circulation. But the only one that has been FDA approved to date is a pulmonary artery pressure sensor. So that'll be the focus of today's lecture. Regardless of where we have implanted a hemodynamic sensor, we have observed the key finding that elevations of pressure, i.e. hemodynamic congestion, begins many days, if not weeks, and sometimes even months before patients develop symptoms and before they have a clinical event such as heart failure hospitalization. So this slide from a recent scientific statement from the American Heart Association on remote monitoring technologies shows this trend that regardless of whether you're monitoring pressure in the right ventricle, the pulmonary artery, or in fact any other location within the circulation, you observe these increases in pressure that occur before the onset of symptoms that drive patients to seek hospitalization for treatment. And so this paradigm has emerged in which we understand now that changes in filling pressure are probably the earliest detectable events in this cascade of decompensation, and that further downstream we are able to detect intrathoracic impedance changes, and certainly the things that we tell our patients to monitor their weights, to monitor their symptoms. These are relatively late events in the cascade of decompensation. So it may not be surprising that our attempts to monitor patients on the basis of these findings have been met with relatively little success. So if we superimpose upon this slide the various trials, you can see where they're located in the decompensation cascade. And today I'm going to focus on the results of a few trials that are shown in bold red here that have emphasized the potential utility of a pulmonary artery pressure sensor in improving outcomes in heart failure. But as I've emphasized earlier, there have been other trials, some published and some not published, or some that are neutral, that have at least shown the potential benefits of monitoring pressure in other locations within the circulation. So the sensor that we're talking about is also known as the CardioMEMS sensor. Again, this is the only FDA-approved sensor, though there are others that are under active investigation. This device is quite small and consists of a sensor that is within two nitinol loops. This device is implanted through an outpatient procedure that involves placing a catheter into the main pulmonary artery and deploying the device. There's no battery, it is completely wireless, and the patient is discharged home with this pillow that contains an antenna. The antenna communicates with the implanted sensor and transmits pulmonary artery pressure trends to a remote secure website that clinicians can then review over time to manage and monitor trends in PA pressure. So one of the first trials in this space that is landmark because it is the first was the CHAMPION trial, which asked the question whether ambulatory hemodynamic monitoring with a wireless pulmonary artery pressure sensor could reduce the primary endpoint of heart failure hospitalization at 12 months. All the patients in this study had New York Heart Association Class 3 symptoms and been hospitalized for heart failure within the preceding 1 year. All the patients underwent implantation of the pulmonary artery pressure sensor, and it was after implant that patients were then randomized to standard of care treatment without knowledge of pulmonary artery pressure, or they were randomized to receive treatment guided by the pulmonary artery pressure. And then there was follow-up at 6 and then 12 months after. And this is the key outcome slide from the study. You can see that for the primary endpoint of heart failure hospitalization on the left side of the screen, patients who received the CardioMEMS device, the pulmonary artery pressure sensor, shown in red, had a significantly reduced rate of heart failure hospitalization compared to those who were treated using standard of care. There was a secondary endpoint that looked at the combined endpoint of hospitalization or mortality. And although the curve separated starting at around 90 days, this was not a statistically significant finding, but it was certainly suggested that there might be a mortality benefit from remote monitoring. And it was ultimately on the basis of this study that the CardioMEMS technology was approved by the FDA for the indication of reducing heart failure hospitalization. And sub-studies and longer follow-up from this trial showed that the benefit of hemodynamic monitoring applied equally to patients with heart failure with preserved ejection fraction as it did to those with reduced ejection fraction, and in multiple other relevant pre-specified and post-hoc subgroups, which I will not have the time to go into today. But suffice it to say, the results were durable and the results were homogeneous across all relevant subgroups. One of the interesting findings from this study is to understand what was the mechanism by which pulmonary artery pressures were reduced. And when the investigators analyzed the treatment response to elevation in pulmonary artery pressure, it became clear that the primary response was to adjust, usually increase, diuretics, both loop and thiazide diuretics. And you can see from this slide that there were also a significant number of decreases in diuretics in response to low pulmonary artery pressure. And there were even fewer adjustments to other medication classes. This, of course, predated SGLT2 inhibitors and predated sacubitril/valsartan. But you can see that titration of neurohormonal blocking agents was relatively rare compared to loop diuretics. Another analysis from this trial did show that there was a synergistic benefit, i.e. patients who were receiving complete neurohormonal blockade with an ACE and an ARB, rather ACE or ARB and a beta blocker, had a synergistic benefit from treatment based on hemodynamics. So this appears that hemodynamic treatment as well as neurohormonal blockade are both important in improving heart failure outcomes. And since many of you may not have personal experience in managing patients who have this type of technology, I wanted to give you an example from my own practice. What we're looking at here are pulmonary artery systolic pressures shown in the red top line, pulmonary artery diastolic pressures shown in the green line, and mean pulmonary artery pressures shown in the blue line. The x-axis here is time, ranging from July 2017 to June of 2021, and the y-axis is millimeters of mercury. These vertical pink bars represent medication change. So this is a patient of mine who was 46 years old when he was implanted with his device. He had heart failure with preserved ejection fraction in the context of a history of congenital heart disease with bicuspid aortic stenosis and aortic coarctation. And by the time I met him in his 40s, he had already undergone a total of 5 corrective surgeries for his underlying congenital heart disease. And he had very elevated pulmonary artery pressures and severe heart failure symptoms. And you can see that over the ensuing 4 years that are represented on the slide, we made a very frequent number of medication adjustments, again, predominantly diuretics. You can see that his pressures were very labile, which is partly telling you about the pathophysiology of his disorder. But the key point that I want to make is twofold. Number one, this patient lives on the Oregon coast, which is about 2 hours from Portland. And we were able to make all of these numerous medication changes in response to dramatic and very dynamic elevations in PA pressure. And yet over the course of these 4 years, he was never hospitalized. The second point that I would like to make is look at the adjustment and intensification of diuretic management that occurred. He went from taking 2 milligrams of Bumex BID and 50 of eplerenone to a very high dose of diuretics that no person who is sane would usually prescribe unless they had knowledge that this person's hemodynamics were severely deranged despite these very high doses of diuretics. So I think this is a very illustrative and educational case to highlight the potential benefits of the technology, and also maybe speaks to the fact that even though we don't consider diuretics themselves to be part of our armamentarium, and we don't consider it necessarily to be a pillar of GDMT, it raises the question as to whether, if we had insights and we were tailoring our therapy in response to hemodynamics, perhaps we would appreciate that decongestion with diuretics does in fact have a more potent clinical benefit than we usually ascribe to it. So the data that I've shown you to date, or to this point in the talk, has suggested the following sort of central dogma. If we implant a pulmonary artery pressure sensor into a patient with heart failure, regardless of their ejection fraction, we have knowledge of their hemodynamics. In response to that, we make a medication adjustment, usually a diuretic adjustment. That reduction, or that intensification, leads to a reduction in pulmonary artery pressure, which we have shown leads to a decrease in heart failure hospitalization. And there has been a suggestion that perhaps either because heart failure admissions themselves reduce mortality, or because of the beneficial effects of PA pressure reduction in and of itself, there's a signal towards reduced mortality. And this question about whether or not hemodynamic guidance can actually reduce mortality was one of the key questions that underlied the next pivotal study, which is the GUIDE heart failure study. And this study extended the studied population to include patients who had class 2 or ambulatory class 4 heart failure, in addition to the class 3 population. And additionally, it no longer required that patients have a heart failure hospitalization in the preceding 12 months, but also could enroll patients who were experiencing worsening heart failure purely on the basis of an elevated natriuretic peptide level. Similar to the CHAMPION study, these patients were all implanted with the device and then randomized to treatment or control, and follow-up was at 12 months. Now, many of you may know that this study did show that there was a favorable and statistically significant difference in pulmonary artery pressure at the end of 12 months. However, this did not translate into clinical benefit. Again, there was a trend, but it did not reach statistical significance in the combined endpoint of heart failure hospitalization, all-cause mortality, and urgent heart failure visits. Now, this trial, of course, occurred during the COVID pandemic, and the investigators performed an analysis of these trial results, focusing on the event rate before the COVID pandemic was recognized as a national emergency, and compared it to events that occurred after. And if you focus just on the pre-COVID analysis, you do see that, in fact, there is a statistically significant benefit of hemodynamic monitoring on the primary endpoint that is driven predominantly by reductions in heart failure hospitalization. The authors further investigated what happened during the pandemic that can explain these results. So if you look at changes in pulmonary artery pressure on the top of this slide, this is during the pre-COVID analysis, you can see that the control group, shown in red, had higher PA pressures than the treatment group, shown in blue. During the pandemic, there was no significant downward trend in the treatment group, but you can see that the control arm pressures fell to the same level or a comparable level as the treatment group. And that reduction of pulmonary artery pressure in the control group essentially nullified the treatment effect. If you look at the event rate in the control arm, it was 0.682 events per patient year prior to the pandemic. But then once the pandemic began, their event rate dropped to 0.536, which was similar to the event rate in the treatment arm. So this is a very interesting observation. Subsequent analysis or additional analysis in this paper indicated that this was not due to changes in treatment. It was not due to changes in intensity of follow-up, and really had to do with patient-related factors that we can only speculate, but one can assume that the pandemic likely led to either greater adherence to medical management, perhaps patients ate out less or ate better, and therefore there is certainly suggests a behavioral component to heart failure in this patient population, but we can only speculate. One of the interesting observations from the pre-COVID analysis is that, in contrast to many of our novel and newer medications in heart failure, i.e. SGLT2 inhibitors and Entresto, which seem to have less benefit at the extremes of ejection fraction, the benefits of hemodynamic monitoring seem to be consistent across the EF continuum. So this is true whether you look at a primary endpoint of combined mortality, heart failure hospitalization, or urgent heart failure visit, since that outcome is primarily driven by the reduction in heart failure hospitalization. You can see that on the right-hand side of the screen. That is a line across the EF continuum showing a very consistent reduction in the hazard ratio for heart failure hospitalization. So that makes this a unique therapeutic option, or at least a monitoring option that has therapeutic implications for patients regardless of ejection fraction. And then most recently was the publication of the Monitor heart failure study. This took place at 25 sites in the Netherlands. And unlike Champion and unlike Guide heart failure, patients were randomized to receive a CardioMEMS device or continue standard of care. So in other words, randomization did not occur after implant. So there's the potential for there to be a placebo effect, or there was no sham essentially. The primary endpoint here was Kansas City cardiomyopathy questionnaire scoring, and you can see that patients who received the therapy shown in blue had improved KCCQ scores across multiple domains. And when we look at a clinical endpoint, which was a secondary endpoint of heart failure hospitalization, you can see, as we've seen in other trials, this consistent benefit in reducing heart failure hospitalization. And subsequent analyses again showed that this was due primarily to adjustments in diuretics. And then most recently presented at THT this year and currently awaiting manuscript publication is a meta-analysis of Champion, Guide, and the Laptop HF study. Laptop was a trial looking at a left atrial pressure sensor that was terminated early due to a greater than expected rate of implant complications. That study was never published, but since data became available at a patient level, the data from that study, as well as the other pulmonary artery pressure studies, were combined. And when one looks at the endpoint of survival in this meta-analysis, there is a 25% relative reduction in mortality using hemodynamic monitoring, and again, a 36% reduction in heart failure hospitalization at 1 year. Again, so we see this sort of consistent signal across these 3 trials. So currently, hemodynamic monitoring with a pulmonary artery pressure sensor is currently given a level of evidence of 2B, or strength of indication of 2B in our heart failure guidelines. These guidelines may be updated in response to the meta-analysis and the Monitor HF trial that I just showed you. So in conclusion, patients who have heart failure, regardless of ejection fraction, are at high risk of clinical events despite optimal medical and device therapy. Most heart failure hospitalizations are caused by worsening congestion. Remote monitoring of symptoms or surrogates has really not been effective in reducing heart failure events. We know that monitoring of pulmonary artery pressure on an ambulatory basis results in changes in diuretics, which seem to have hemodynamic and clinical improvement in clinical trials. These benefits of monitoring seem to be independent of ejection fraction. And I will just add as an editorial comment that this field is rapidly evolving. There are multiple new technologies that are being developed, and there are additional pulmonary artery pressure sensors that are currently being investigated in large-scale trials. Outside of the clinical utilization of remote monitoring, I made a reference to HF squared. I'll just make a minor self-promotion here. This is an academic consortium at multiple sites shown on this slide, where we're very interested in the use of remote monitoring to actually advance the development of novel technologies for heart failure, as well as better understanding and stratifying our existing therapies based on knowledge of hemodynamics. So hopefully we'll be able to shed further insights into heart failure pathophysiology and treatment. I thank you for your time and attention, and I'll put up the post-lecture survey, and I'm happy to take any questions. Thank you.
Well, thanks, Jacob, so much for such a wonderful talk. Knew you would present us with some great information and a lot to think about. If anybody out there in the group has a question for Dr. Abraham, please feel free to either unmute yourself or raise your hand, and then we will call on you. So it looks like we have a question here in the chat. Let me see if I can open this. So the question is, how many patients that required increased diuretic doses had deranged renal function or were in cardiorenal syndrome? So I guess I don't know how you might get that information, but I don't know if you want to speak to that type of pathophysiology and how we treat that.
So I can say that in all of these trials, patients who had CKD 4 or higher or were non-responsive, to high doses of diuretics were excluded. From a safety perspective, there were no signal of harm due to diuretic intensification. There have been post hoc analyses looking at this question as well that have showed the safety in patients who have more advanced kidney disease. It's a really important question. I can say anecdotally from our experience that we have seen the relative safety as well of using high doses of diuretics. And again, I think the key is that we are making these adjustments based on knowledge of hemodynamics, as opposed to in the absence of knowing the hemodynamics when we make these changes in response to weight changes, for example, which are nonspecific. That I think is where we're seeing potential harm. I would also be remiss if I didn't highlight the work by Dr. Testani at Yale, which indicates that in the treatment of heart failure, particularly for decongestion, changes in renal function, creatinine, when we are decongesting a patient, don't seem to have the same prognostic significance as changes in renal function not related to heart failure. But I think that's a really important question and one that deserves further investigation.
We have a hand raised, Omar. Omar, if you'd like, you can unmute yourself and ask your question to Dr. Abraham.
Thank you so much. I just have a quick question about, can you compare the CardioMEMS to like one of the pacemaker bioimpedance, or Zoll currently in our hospital is kind of like pushing towards this wearable bioimpedance type of device. Is there a comparison between two, or is there any study that shows that those other ones might be, because like we have patients that have pacemakers all the time and we don't need to implant the new CardioMEMS in them and so forth?
Great question. So there are a number of, so to answer your question directly, there are no head-to-head comparisons of these technologies. I think what the current data from the wearable devices, the other implantable technologies has shown us is that we can stratify risk for future heart failure events based on metrics that come from these devices. What we haven't shown yet is that what response is appropriate, probably diuretic adjustment, but we haven't seen a consistent strategy of managing patients based on their risk leads to an improved outcome. So whether you're looking at a Zoll, whether you're looking at Medtronic, implantable devices, all of these, they now have these risk scores based on heart rate variability, changes in thoracic impedance, et cetera. What we know is that they can stratify risk, but we don't know that treating patients based on that risk leads to an improved outcome. I'm sure that data will come, but thus far we do not have it. And specifically for the Zoll patches, my understanding is that those devices, you have to have the patient quote unquote dry. So you have to look at deviations from when they're clinically dry rather than, a hemodynamic definition of decongested state.
Are there any other questions out there? Well, if not, we'll thank everybody for attending. Oh, there's a new message. Let's see what this is. CardioMEMS measures pressure only. In the inpatient setting with pulmonary artery catheters, much focus is on cardiac output. Oh, with PA catheters, would there be any role for long-term outpatient cardiac output monitoring?
So this is in fact currently being investigated. So it turns out that the CardioMEMS device actually can estimate cardiac output. And there is a trial that is being conducted and may actually be complete called the Victor study, in which patients who are implanted with the CardioMEMS are undergoing rest and dobutamine stress cardiac MRI to compare the CardioMEMS derived cardiac output with MRI derived cardiac output, which is considered the gold standard. And assuming that there is a correlation, then the manufacturer is going to request FDA approval to report cardiac output to clinicians in addition to pulmonary artery pressure, which is something that as a clinician, I will be very excited about.